Pulmonary circulation starts with oxygen poor and carbon dioxide rich blood in the right atrium that flows into the right ventricle. From there, blood is pumped into the large pulmonary trunk, which splits to form the two pulmonary arteries, one for each lung. The pulmonary arteries divide into smaller arteries known as pulmonary arterioles, and then eventually into pulmonary capillaries which surround the alveoli, which are the millions of tiny air sacs where gas exchange happens. At that point, oxygen enters the blood and carbon dioxide enters the alveoli. The pulmonary capillaries drain into small veins known as pulmonary venules that flow into two pulmonary veins exiting each lung. And these pulmonary veins complete the circuit by delivering oxygen-rich and carbon dioxide-poor blood into the left atrium, which flows into the left ventricle and then into the aorta where it enters systemic circulation. Normally, about 2% of the blood follows a slightly different path. It's diverted or shunted so that it bypasses the pulmonary capillaries. And this is called a physiologic shunt. There are two main ways this happens. First, when blood goes out to the heart muscle itself, it returns through tiny veins called Thebesian veins. Rather than draining into the venous system and going into the right atrium, these veins sometimes dump that blood into the closest chamber of the heart. So, for example, if blood that goes out the aorta and through the coronary arteries to the muscle in the left ventricle of the heart, then the deoxygenated blood might then drain directly into the left ventricle chamber of the heart. At that point, it would mix with the rest of the oxygenated blood and get squeezed right back out through the aorta. So this blood basically bypasses the pulmonary circulation. Second, the conducting airways of the lungs, like the bronchi, receive systemic arterial blood from the bronchial arteries. But the deoxygenated blood can flow, or anastomose, right into nearby pulmonary veins which are carrying oxygenated blood that has already traveled through the pulmonary capillaries. So once again, deoxygenated blood might flow right into the pulmonary veins and mix in with the rest of the oxygenated blood, bypassing the pulmonary circulation. Now, in addition to these naturally occurring physiologic shunts, there are also some pathological defects that can lead to more shunting of blood. In most left to right shunts, blood flows from the left side of the heart to the right side of the heart. This can happen when there's a gap in the wall, or septa, that divides the left and right chambers of the heart. So, for example, a ventricular septal defect allows blood to flow down its pressure gradient from the high pressure left ventricle into the lower pressure right ventricle. And an atrial septal defect allows for the same thing, only blood is shunted from the left atrium to the right atrium. Another type of left to right shunt happens with a patent ductus arteriosus. The ductus arteriosus is a fetal blood vessel that creates a pathway for blood to flow from the pulmonary artery into the aorta. During fetal development, this is important because the lungs are not working and are fluid-filled and compressed. So oxygenated blood coming from the placenta bypasses the lungs and goes directly into fetal systemic circulation. This pathway is supposed to close at birth and allow blood to flow normally from the right ventricle into the pulmonary artery and into the lungs. But in some babies, it remains open, or patent, and that allows blood to flow from the high-pressure aorta into the lower-pressure pulmonary artery. The end result of any of these left-to-right shunts is that oxygenated blood is making a second loop through pulmonary circulation, which means that the right ventricle is doing a bit of extra work, moving blood around that's already oxygenated. On the flip side, in a right-to-left shunt, blood flows from the right side of the heart to the left. Normally, this wouldn't happen, because blood would not want to flow up its pressure gradient. But right to left shunts typically involve changing pressures in the chamber of the heart, which reverses the gradient. So, for example, in the congenital heart condition called tetralogy of Fallot, there's a large ventricular septal defect and stenosis, or narrowing, of the right ventricular outflow tract into the pulmonary artery. The right ventricular outflow tract stenosis increases the resistance to blood going into the pulmonary circulation, and that increases right ventricular pressure. If the right ventricular pressure exceeds left ventricular pressure, then blood can flow down the new pressure gradient, and a right to left shunt happens. Another example is Eisenmenger syndrome, which is caused by pulmonary hypertension. Basically, what happens is that pulmonary hypertension, which can result from a left to right cardiac shunt, can get so severe that the pressures on the right side of the heart exceed the pressures on the left side, leading to a right to left shunt. Ultimately, in a right to left shunt, oxygen poor and carbon dioxide rich blood mixes with the oxygen rich and carbon dioxide poor blood that's already gone through the pulmonary circulation. The mixing causes oxygen levels to fall in the arterial blood, leading to hypoxemia. And supplemental oxygen does not bring levels back up because the blood going through the pulmonary capillaries is already saturated and can't pick up any more oxygen in the short time that the blood is going through the pulmonary capillaries. On the other hand, if there's even a slight rise in carbon dioxide levels, it's detected by central chemoreceptors in the brain, which promptly increase the respiratory rate. Carbon dioxide in the alveoli and blood equilibrates about 20 times faster than oxygen. So unlike oxygen exchange, which is physiologically maxed out, any excess carbon dioxide can quickly diffuse out of the blood and return to normal physiologic levels. In fact, it's the decrease in oxygen levels that can actually be used to calculate the amount of blood flow through the shunt, in liters per minute, using the shunt fraction equation. Mathematically, if the total amount of blood flow, or cardiac output from the left ventricle, is QT, then it equals the amount that's shunted, or QS, plus the amount that goes through the pulmonary capillaries, or QC. Based on this, the shunt fraction is the proportion of blood flow through the shunt over the total blood flow. Similarly, the oxygen content in the cardiac output, which is the arterial blood, or CaO2, is equal to the oxygen content of the blood flowing through the shunt. And remember that it's venous blood that's diverted through the shunt, or CVO2, plus the oxygen content of the blood flowing through the pulmonary capillaries, or CCO2. Now, the more blood flow, the more red blood cells there are to carry oxygen. So oxygen content is affected by blood flow, and we can multiply QT by CaO2, QS by CVO2, and QC by CCO2. Now we can arrange the total blood flow equation to substitute QC with QT minus QS. Now, the goal is to solve for QS divided by QT. So we can first distribute CCO2 to get QT multiplied by CCO2, minus QS multiplied by CCO2. Now, let's get all of the QS parts of the formula on one side of the equation, and all QT parts on the other side. Next, we can factor out QS to get QS times CCO2 minus CVO2, and do the same thing to QT to get QT times CCO2 minus CaO2. Now we divide both sides of the formula by QT, crossing it out from the right side, leaving us with QS times CCO2 minus CVO2 divided by QT. And then divide again by CCO2 minus CVO2 on both sides to get rid of it on the left side. So we're left with the shunt fraction equation, QS divided by QT. The numerator has CCO2 minus CaO2, which is the oxygen content of the blood flowing through the pulmonary capillaries minus the oxygen content in the arterial blood. That difference represents the oxygen-poor CVO2 blood coming from the shunt and mixing with the oxygen-rich CCO2, thereby causing CaO2 to fall. And the denominator is CCO2 minus CVO2, the oxygen content of the blood flowing through the pulmonary capillaries minus the oxygen content of the venous blood. This value isn't affected by the shunt at all, since oxygen-rich CCO2 and oxygen-poor CVO2 blood coming from the shunt represent values before the two get mixed together. Alright, as a quick recap. A shunt is a rediversion of blood from its usual path through the pulmonary circulation. Shunts can be physiologic or pathologic. They can also result in a left to right or right to left diversion of blood across the heart. The amount of blood that flows through a right to left shunt can be calculated using the shunt fraction equation, which is based on oxygen content of the blood. Alright, so pulmonary circulation starts with the right ventricle. From there, blood is pumped to the large pulmonary trunk, which splits to form the two pulmonary arteries, one for each lung. The pulmonary arteries divide into smaller arteries known as pulmonary arterioles, and then eventually into pulmonary capillaries which surround the alveoli, which are the millions of tiny air sacs where gas exchange happens. At that point, oxygen enters the blood and carbon dioxide enters the alveoli. The pulmonary capillaries drain into small veins that join to form the two pulmonary veins exiting each lung. And these pulmonary veins complete the circuit by delivering oxygen-rich blood into the left atrium. Pulmonary blood flow, or Q, is the volume of blood, usually in milliliters, that's being pumped out of the right ventricle over time, usually in 1 minute. Said differently, pulmonary blood flow is the cardiac output of the right ventricle. The cardiac output is the stroke volume, or the volume of blood pumped per beat from the right ventricle of the heart, expressed as milliliters per heartbeat, multiplied by the heart rate in beats per minute. Now, pulmonary blood flow is directly proportional to the difference in pressure between the pulmonary arteries and the left atrium, or delta P, and inversely proportional to the resistance of the pulmonary vasculature, or R. The blood pressure and resistance in the pulmonary circulation is normally a lot lower than the systemic blood pressure. The normal pulmonary artery pressure is about 25 over 10 millimeters of mercury, with a mean arterial pressure of 15 millimeters of mercury. If pulmonary blood flow needs to change in response to a situation or vasoactive substance, it's done by changing the resistance of the vasculature, particularly the arterioles, which is related to the diameter of the blood vessels. Specifically, a decrease in the diameter of the arterioles causes an increase in the resistance, and that leads to a decrease in blood flow. On the other hand, an increase in the diameter of the arterioles causes a decrease in resistance, and that leads to an increase in blood flow. Now, in the lungs, tiny capillaries surrounding the alveoli are called alveolar vessels, whereas those that are located further away, like arterioles, are called extraalveolar vessels. And the sum of the resistance in both the alveolar blood vessels and extraalveolar blood vessels determines the total resistance of the pulmonary vasculature. Alveolar blood vessel resistance depends on alveolar air pressure, because the blood vessels share a basement membrane with alveoli and therefore feel the pressure directly. As a result, if alveolar air pressure is high, that can crush or close up an alveolar blood vessel. And if alveolar air pressure is low, that can allow the alveolar blood vessel to open up. In contrast, extraalveolar blood vessel resistance depends on pressure in the pleural space, which lies between the parietal pleura, which is stuck to the chest wall, as well as the visceral pleura, which is stuck to the lungs. Pressure within the pleural space is established by two main opposing forces. One is the muscle tension of the diaphragm and chest wall, which contract and expand the thoracic cavity outwards, and the other is the elastic recoil of the lungs, which try to pull the lungs inward. The two forces pull on each other, creating a slight vacuum in the pleural space, which results in a pressure of -5 centimeters of water, relative to the pressure of 0 centimeters of water in both the thoracic cavity and within the alveoli of the lungs. Based on this, one way to control pulmonary vasculature resistance is through changes in lung volume. When lung volume is high, like at the end of maximum inspiration, alveoli are extended and the alveolar pressure increases, pressing down on and applying increased pressure on the alveolar blood vessels. The result is that alveolar vessels constrict and resistance increases. But also during maximum inspiration, pleural pressure is negative, and that means that lung tissue expands outward, pulling open the extraalveolar vessels and decreasing their resistance. When lung volume is low, like at the end of maximum expiration, everything is reversed. Alveolar pressure decreases, dilating the alveolar vessels and decreasing alveolar blood vessel resistance. Meanwhile, pleural pressure becomes less negative, compresses the extraalveolar blood vessels, and increases extraalveolar blood vessel resistance. So, since total pulmonary resistance is the sum of alveolar vessel and extra-alveolar resistance, total pulmonary resistance is highest at either lung volume extreme, at maximum inspiration when alveolar resistance is high, and at maximum expiration when extra-alveolar resistance is high. Total pulmonary resistance is the lowest when vessel resistances are at their lowest, which is at passive expiration. That's the point just before either forced expiration or inspiration happens. Now, another way to control pulmonary vasculature resistance is by vasoconstriction of the pulmonary arterioles, which increases resistance, as well as vasodilation of the pulmonary arterioles, which decreases resistance. Vasoconstriction and vasodilation are controlled by the smooth muscle that wraps around the arterioles. A trigger for smooth muscle contraction is a decrease in the partial pressure of oxygen within the alveoli, which is called hypoxic vasoconstriction. Typically, the partial pressure of oxygen is 100 millimeters of mercury. But let's say some area in the lung is diseased or damaged, like a pneumonia in the left lower lobe. The partial pressure of oxygen in those alveoli might only be 70 millimeters of mercury, and that would decrease oxygen delivery to the blood flowing to that region of the lung. So what happens is that in response to the low levels of oxygen in the alveoli, the smooth muscle that wraps around the arterioles just upstream of the alveoli start to vasoconstrict. This shuttles blood away from those damaged areas of the lung, and towards healthy lung tissue where the partial pressure of oxygen is higher and the blood can be oxygenated more efficiently. But hypoxic vasoconstriction can also happen globally, throughout the entire lung, like at high altitudes, or during widespread lung disease, like emphysema, or in fetal circulation when the baby isn't breathing. These can all cause a decrease in partial pressure of oxygen throughout the lungs, and that can lead to widespread vasoconstriction of the pulmonary arterioles. That leads to an increase in pulmonary vascular resistance, and increased resistance makes it harder for the right ventricle to pump out blood, kind of like pushing water through a narrow pipe as opposed to a wider pipe, so blood flow decreases. To make the same amount of blood flow through the pulmonary arterioles, the right side of the heart has to generate increased pressure. In chronic situations, that results in pulmonary hypertension. In fetal circulation, only about 15% of the blood from the right ventricle actually flows to the lungs, and this lower level of blood flow is maintained by diverting the remainder of the blood to the left side of the heart so that it bypasses the lungs. In addition to hypoxia, another smooth muscle regulator is arachidonic acid, a 20-carbon fatty acid found in cellular membranes of many cells throughout the body. In response to cellular injury and inflammation, arachidonic acid can be metabolized by some cells using the cyclooxygenase pathway. The cyclooxygenase pathway results in thromboxane A2 and prostaglandin I2, which are vasoactive metabolites that bind to and affect the smooth muscle cells. Thromboxane A2 is produced by leukocytes in lung tissue and causes vasoconstriction, while prostaglandin I2 is produced by lung endothelial cells and causes vasodilation. In addition, when there's endothelial cells of the pulmonary vasculature produce nitric oxide. The nitric oxide then enters nearby smooth muscle cells and causes them to vasodilate. Alright, as a quick recap, pulmonary blood flow is the cardiac output of the right ventricle. It can be calculated using the formula Q equals the difference in pressure between the pulmonary artery and the left atrium, or delta P, divided by the resistance of the pulmonary vasculature, or R. The resistance of the vasculature can be changed by lung volume and vasoactive substances, which can constrict or dilate the vasculature to ultimately regulate the pulmonary blood flow. Air from the environment enters through the nostrils, goes through the airways, and finally reaches the alveoli, which are the tiny air-filled sacs in the lungs. Here, gas is exchanged between the alveoli and the blood flowing through the capillaries that surround each alveolus. And blood flows from the higher pressured arteriole to the lower pressured venule. Now, P big A, which is the pressure within the alveoli of the lungs, is relatively constant throughout the lungs. At the end of expiration, it's equal to atmospheric pressure, which is 0 centimeters of water. And although the pressure in the arterioles is greater than the pressure in the venules, their values change at different vertical levels within the lungs. Consider the fact that some blood vessels are more vertical while others are more horizontal. The horizontal ones are unaffected by gravity, but the more vertical ones are affected by gravity. The analogy would be a cylinder filled with water. The cylinder represents a blood vessel and the water would be the blood. As you add more and more water, the height of the water increases. And when the column is completely filled, the pressure from the water that's exerted on the bottom of the cylinder, or hydrostatic pressure, is equal to the density of the water multiplied by gravitational acceleration, multiplied by the height of the column of water above it. Blood in vertical blood vessels in upright lungs have similar hydrostatic effects. At the apex of the lung, pressure in the arterioles and venules are relatively low. At the base of the lung, pressure in the arterioles and venules are relatively high. And in the middle of the lung, the pressures are somewhere in between. Now, because the pressure in the alveoli is constant, the relationship of the pressure in the arterioles and the venules with respect to the pressure in the alveoli changes. And it's the relationship between these three that determines the zones of the lungs. In zone 3, at the base of the lungs, pressure in the arterioles is higher than in the venules, but both are higher than the pressure in the alveoli. In zone 3, blood flows through the capillaries because of the pressure difference between pressure in the arterioles and pressure in the venules. Now, even though the pressure in the arterioles and venules exceeds the pressure in one adjacent alveoli, the protein and cells that make up the walls of the alveoli are strong enough to resist collapsing. In zone 2, in the middle to top, or apex of the lungs, pressure in the arterioles is higher than pressure in the alveoli, but pressure in the alveoli is higher than the pressure in the venules. In zone 2, as before, blood flows through the capillaries because of the pressure difference between the pressure in the arterioles and the venules. And also as before, the alveoli don't get crushed despite the higher pressures in the nearby arterioles. Now, here the alveolar pressure is greater than the venule pressure, and the blood vessels feel the pressure directly because they share a basement membrane with the alveoli. This causes the venules to get slightly crushed, decreasing their diameter, and increasing their resistance, which leads to a decrease in blood flowing through them. But arteriolar blood continues to flow into the venule, overcoming that external pressure. It's kind of like a clothespin pinching down a bit on a straw. If you blow air into one end of the straw, the clothespin will make it harder for air to get through the other side. But if there's enough pressure, then the air will overcome the resistance and make it through. In zone 1, at the extreme apex of the lungs, pressure in the alveoli is higher than pressure in the arterioles, which is still higher than pressure in the venules. In this zone, blood does not flow because the arterioles get crushed by the relatively higher pressures in the nearby alveoli. Now, normally, the structure of blood vessels and alveoli allow them to resist completely collapsing. So this only happens in non-physiologic conditions, like when pressure in the arterioles decreases drastically, like during a hemorrhage, or when pressure in the alveoli increases drastically, like during positive pressure ventilation. During these times, the pressure in the alveoli can crush the capillaries and completely cut off blood flow, creating dead space. Alright, as a quick recap. Pulmonary blood flow through the 4 zones of the lungs is unequal, and it's driven by the effects of pressure gradients in blood vessels as well as the pressure within alveoli. In zone 3, in decreasing order, there's pressure in the arterioles, then pressure in the venules, and then pressure in alveoli. In zone 2, pressure in the arterioles, then pressure in alveoli, and then pressure in the venules. In zone 1, at the extreme apex, which normally doesn't happen under physiologic conditions, you have pressure in alveoli, then pressure in arterioles, then pressure in the venules.